Welcome, family, to another episode of the Stay Juicy podcast. I'm your host, Dr. Arianna, and today we're going to dive right into it. I have been giving some thought around the fact that the FDA has removed the black box warning from all estrogen products, and I've been getting a lot of questions around it. And this episode, I wanted to continue to discuss some of the data that was released and discussed at the Menopause Society meeting this past October, but I'm still going to be referencing a lecture. This one is really around estrogen. When do we start it? When do we stop it? And just getting a better understanding of its safety profile. And I thought that would be nice to kind of wrap into the fact that the FDA has removed the black box warning. And I want to kind of give you all some historical perspective to help you understand really what's happening now. Also, in light of the fact that, it is not lost upon me that you all get a lot of information from TikTok. I have people sending me stuff all the time. And, I'm really happy that menopause is having a moment. I also, though, don't want us to fall into the same trap that we did when the WHI study was released and everyone got on the estrogen is bad bandwagon. And it really informed over 2 decades of how we train providers, our understanding of the female body, and really the suffering of, frankly, millions of women that did not have the benefit of at least being informed about the safety and efficacy of estrogen. So what I want to do in this episode, first of all, is kind of break down the understanding and the politics around the FDA removal of the black box warning. But I also want to help you understand and just give you a refresher on estrogen, where we are, what's good, what's bad, what's the ugly. And as usual, friends do not let friends go through perimenopause and menopause alone. So share with a friend and inform. If it's not the podcast, then just share. As women, we need to have these conversations. We need to talk to each other. We should not be suffering in silence. And far too many of you all I know are dealing with so many symptoms and not having these conversations. And I really think it's important to reach out and to find someone who may be experiencing some of the things that you are experiencing on this journey. Have those conversations, support each other. It can be very meaningful. So let's start with the FDA and what happened last week. By the time you all get this, it'll be a few weeks that the FDA has now removed the black box warning. And really, the black box warning actually started around 20 years ago, and it coincided with the release of the WHI study, the Women's Health Initiative study, which basically was a longer term study looking at the impacts of estrogen and lifestyle and all types of things in women. It wasn't a study designed to look at the impact specifically of estrogen. And so the way the data was released was confusing. And frankly, some of it was manipulated in a way that really affected women's health for the 20 years. And it shaped a whole generation of fear and confusion and ultimately undertreatment of women. But 2002 is when the WHI study came out. And that was really a misinterpretation of the study. And instead of pausing and kind of analyzing the data, the whole system kind of panicked. And clinicians pulled everybody off of therapy overnight. Prescriptions actually dropped 80% after this study was released. And millions of women, like I said, they suffered unnecessarily. And the truth is that the black box warning never supported the full weight of evidence of why it had been put on that list. Black box warnings were generally and still are for medications and things that we know have severely detrimental effects and where the benefit must absolutely outweigh the risk because the risks are clear and documented. And that was never documented with estrogen. It wasn't documented then. It's not now. And it really has not been in the 2 decades of research that has followed. There's never been any evidence that has really supported the type of fear and confusion that study created. And finally, the FDA acknowledged that the risk for the average healthy woman really was, again, overstated. And they understated really what the benefits could be. And that's where it really went sideways, because it's one thing to overstate the risk, but to understate the benefits is another thing. And what we do know is that estrogen is the most effective treatment for hot flashes and night sweats, hands down. We know that estrogen protects bone. It improves sleep, mood, vaginal health, and ultimately the quality of life. And yes, I always have to do my disclosure of, am I a hormone pusher? No, but for women who are suffering and who really need some relief, it is really important for you at least to understand that estrogen has so many other benefits and that the risks don't even come close to what some of the benefits can bring. And also, we know that estrogen can be used safely. We're going to talk about that a little bit more, because the other question that comes up is, well, okay, I started the estrogen, but how long can I stay on the estrogen? And so the study, the WHI study, really enrolled women that were much later on. The average age were women more closer to their mid 60s as opposed to mid 40s and 50s, which is when that menopause transition is actually going to be experienced. And so even the demographic of the women that they studied just, again, was very confusing. And the breast cancer risk was completely blown out of proportion. I mean, I can say that out loud now. I do feel like, even though I don't always love the way things are being introduced to the public, I mean, the fact that the FDA took the black box warning off was good. It was initially designed to take the black box warning specifically off of vaginal estrogen. And full disclosure, I'm not really sure how we got to all estrogen products. I'm sure there's a story there. And when it was explained at the conference where they decided to remove this, they kind of overstated some of the health benefits, I think, of estrogen. And even though the pendulum is swinging, we don't want it to swing so far the other way that now we're giving misinformation the other way. One of the comments that were made is that estrogen can decrease the risk of dementia. And that isn't exactly true. Dr. Pauline Mackey, who is really one of the top researchers in this area and has been very clear about the benefits. She, as a scientist herself, wanted to believe that estrogen could decrease the dementia risk in women. And even after her work and multiple studies that followed, we recognize that estrogen really does not do that. We know that estrogen decreases hot flashes, which can help sleep, which ultimately can help cognition. And so there is a relationship with all of this, but not only do we want to not throw the baby out with the bathwater, we don't want to, take everything kit and caboodle, meaning estrogen is not the panacea and it is not the answer, and it is not going to reduce your risk for everything under the sun. But again, we do know that it does protect bone. It is very important for vaginal health, which is a whole nother conversation. This genital urinary syndrome of menopause, it really includes things that happen internally in the vagina, but also around the urethra, our risk for urinary tract infections, the pain with intercourse, and just the overall discomfort that women can experience as a result of declining estrogen in the vulva and vaginal area. So for 23 years, though, we were told to fear a therapy that actually, when used appropriately, has one of the best safety profiles that anything has in menopause medicine right now. And now that the black box is gone, the door is technically open for better care, but we need to have more conversations, really analyzing the data, because we don't want to, again, confuse ourselves around what estrogen is good for and what it can prevent. And when we can start it and stop it, we really need to slow down and, again, absorb this data and understand it. And so that's what I want to do today. So one of the lectures at the Menopause Society was starting, swapping, and starting, swapping, and stopping hormone therapy. And this was given by Dr. Risa Kagan. And she oftentimes speaks at our meetings and has been practicing in this space for 40 years now and is a wonderful resource. And again, she spoke basically around a few topics. One around the timing of when do we actually start estrogen? When is it safe? Now, the timing hypothesis is really real. We do want to start estrogen, and there is data that supports that we want to start it within the 10 years of our final menstrual period or before age 60. Now, that is going to vary. I did have a woman who was, still having menstrual cycles at 60. So, for some populations that isn't an exact number, but at the end of the day, we do want to start it sooner than later and closer to when our last menstrual period is. And what is that? Why is that? That is because as we get older, we know that we are now at risk for other things, such as the cardiovascular disease, the heart disease, which is the number one killer. And so we don't want to add estrogen in, especially if we're taking it in a way that could affect our cardiovascular risk. And I'm going to get into the actual ways that we can take estrogen, right? So transdermal versus oral versus pellets. We're going to talk about the safest way to do that. But at the end of the day, the timing hypothesis is real, and we know that we're going to get the best neurologic and cardiovascular benefit of taking estrogen when we started within those 10 years. Estrogen is the first line treatment for vasomotor symptoms. There are new drugs out on the market. One just came out a few weeks ago. Actually, it was FDA approved during the Menopause Society conference. So Veoza has been out for a couple of years. That was the first to market for treating vasomotor symptoms. It works centrally in the brain, affecting really receptors in the hypothalamus. We call these neurokinin 3 receptors, and it affects in the brain. It has effects in the brain that ultimately will help our sleep and stop hot flashes, but it does not have the systemic other impact that estrogen has on the body, but it will help in diminishing the hot flashes, and that's really important. And Luquet, I believe it's the newer drug that came out from Bayer, and it's very similar to the Veoza, working the same way on these neurokinin receptors in the brain and basically affecting the way our bodies, our heat centers in the body and how we're able to thermoregulate. So there are centrally acting drugs, but they don't give the same impact that estrogen has on the tissue, on all of our tissue. But the breast cancer risk of estrogen, which I was starting to kind of elaborate on, is especially now that these black box warnings have been taken off, understand that the breast cancer risk alone of estrogen is neutral. In fact, in certain populations, it's even reduced. So if you take estrogen by itself, especially in the earlier perimenopausal years, we know there's a decreased risk of breast cancer. And this is finally information that people are beginning to accept and understand. But for the last 23 years, we've taken this WHI study, just taken all of it to heart and kind of, again, thrown the whole baby out with the bathwater and really labeled estrogen as the boogeyman. Estrogen, if it is combined with progesterone, which most people are going to have to if they have a uterus, it does carry a very small added risk. And we're really starting to wonder if that risk is more related to the progesterone itself. And if we are using natural progesterone, the micronized progesterone, which is different than the progesterone that they use in the WHI study, there are definitely studies that show that that risk really does not exist. So I do think there's a little bit more of teasing out of the data there. At the end of the day, I think it's safe to say that estrogen and natural progesterone generally are fairly neutral in terms of the breast cancer risk. And if you want to go so far as to say that combining it with progesterone does increase your risk, it's not going to increase your risk any more than drinking a glass of wine a day. So I put that out there because we want to think about, taking estrogen, or is this safe? It's going to cause cancer. But we're not talking about the fact that, you're 20 pounds overweight, you're not moving your body, you're not sleeping, and, you have elevated cholesterol. Like, those are all things that are far worse from you, not to mention the alcohol and the drinking that, we were kind of led to believe that, a little bit of wine is good for us. No, actually, there's no amount of alcohol that's actually really good for us. And alcohol, at the end of the day, is a carcinogen. What is a carcinogen? It is something that causes cancer. There is a direct link. I would encourage people that if you're so afraid around estrogen, I hope that you have that same fear around alcohol. And if you're not going to take estrogen, then also mitigate your risk of breast cancer and other cancers by understanding the impact that alcohol and excess weight have on your cancer risk, which is frankly greater than taking estrogen. With that said, really most of the contraindications that were described around taking estrogen are just not there, and they haven't been supported. They never were supported. And now we get to speak freely. I feel like I've been kind of underground with some of this messaging around estrogen because the medical community hadn't completely just dove in and embraced it. And now we really are hearing much louder voices. This is information that I've had for over a decade now. And honestly, they were in more fringe circles. Someone who's studying functional medicine and integrative medicine, going to conferences, they've been talking about this for a long time. They were ahead of the game. And so now I'm happy to report that our conventional medical colleagues have caught up. They're sounding the horn, and we are able to at least have reasonable conversations around what estrogen does and what it doesn't do. And that is progress. So let's talk a little bit more about estrogen. I spoke a little bit about when you might start that. Understand that everybody may not need estrogen early in their perimenopause journey. As a matter of fact, I start a lot of women on progesterone, natural progesterone. It's wonderful for sleep. It affects GABA receptors in the brain. It can help for some women with irritability, although there are a subpopulation of women that they just don't do well on progesterone. No matter what, they get either kind of more severe depression, irritability. They just like really feel like it's just not, them and progesterone don't get along. And so there's a small subset of patients, but the average patient that I put on progesterone, although it is not designed for sleep, it is a fact that a lot of women that take it report much better sleep. And that is, again, it wasn't so much of a controversy. It's just if you look at the data and specifically how it affects sleep, it is not a sleeping pill, but we know that it does it can improve sleep in a lot of patients. A lot of patients don't need estrogen. Remember that the reason why your periods are getting wonky is that you're having what we call anovulatory cycles. Those are cycles that you're not ovulating. And when you ovulate, each time you create a corpus luteum, that corpus luteum creates progesterone, and that progesterone estrogen balance is that perfect balance that really brings your cycle into its kind of yin and its yang, where the lining builds. And then 14 days after each ovulation, you will shed. That is consistent across all women. Your cycles might be different in terms of timing, but from the time a woman ovulates to the time she ultimately sheds that uterine lining is 14 days. And so where we vary is the first half of that follicular, let's just call it the first half of the cycle is where we are going to differ, as opposed to that point from where we ovulate. From 14 days from ovulation, we're going to have a menstrual cycle. So getting back to progesterone, earlier on during this transition, you may not need estrogen. Remember, your levels of estrogen are fluctuating wildly, and that's really where your symptoms are coming from. They're really coming from the fluctuation. They're not necessarily coming from the low estrogen levels, although as you go through this transition, your levels will ultimately decline. But the erratic nature of estrogen going up, high levels, going down, that is what is really driving a lot of the experiences, the symptoms that we're having during the perimenopause. So we may start a little bit of progesterone before we start estrogen in this perimenopause journey. But by the time we're ready to start estrogen, what type of estrogen may we start? So transdermal estrogen, at the end of the day, is the safest way to take estrogen. There are oral formulations of estrogen. There's one in particular that combines estrogen with progesterone, which is very convenient. But at the end of the day, especially if you have a very high cardiovascular risk, you have a high BMI, you suffer with metabolic syndrome or any migraine headaches, you definitely do not want to take oral estrogen. Transdermal estrogen has a lower risk of causing any type of clotting or stroke risk. In fact, we pretty much said that it is safe to take in these patients. And it's been a lot of hesitancy around using estrogen in these patients, but we know that the transdermal route does not doesn't have that first pass impact in the liver, and we're going to have better outcomes in terms of our cardiovascular risk. And as I mentioned, if we combine the estrogen with the progesterone, we're going to say that increases your risk probably around the amount of you drinking 1 glass of wine a day. You may want to understand transdermal estrogen a little bit better. It is a patch. We apply it to the lower abdomen. It's going to last you about half the week. Usually I say, you're going to wear the first patch for about 3 days, the next patch for the next 4 days, unless you want to just get really anal about 3.5 days. It stays on. It stays on. I slap my patch on. I get in the jacuzzi. I sit in the tub. And so the patch works through all of that. It stays on and it works quite well. And you're going to want to start that. If you're having hot flashes, night sweats, it's a good chance that it's time for you to consider that. If that's an option that you're looking at. And again, the sooner you start it in some ways, then you actually are decreasing certain risk in ways, because if you already have developing heart disease, if you already have plaque formation, if you already have certain risks, and you go and especially take an oral form of estrogen, then we may be increasing the risk of some other things. Again, stroke, thrombotic events. And that's not obviously what we're going for. So, but in healthy women, especially in the early part of their perimenopause journey, that's really not as relevant. And so you want to start it earlier than later. Number one, if you are only taking estrogen, then theoretically you will lower your breast cancer risk. Even the WHI study showed that. There's actually no controversy around that comment. And also, we don't want to take it again when we've already started to have other cardiovascular issues starting. But we also know that going through this transition is when we're going to be losing the most amount of bone. And we know for a fact that estrogen is going to help in supporting bone loss and to basically will protect our bone loss. And this is so super important. So earlier tends to be better. Earlier meaning you're having symptoms, vasomotor symptoms specifically. And guess what? You may have to switch formulations. You may start with a transdermal patch and you may start with oral, and you might go to a patch. You might go to a gel. Some people they can't tolerate the patch because of the adhesive on it. And so I have to give them a gel that they basically apply every day. And sometimes we have to adjust the dose. So just, if you started estrogen and you're like, oh, I started bleeding, I started having breast tenderness or this or that, know that the goal is symptom control. And sometimes we miss the mark. Sometimes we got to reverse it back. Sometimes we got to lower the dose. Sometimes we got to increase the dose. Sometimes we have to give you more estrogen and more progesterone, or less estrogen and more progesterone. Being with a provider who definitely is familiar and feels confident in working and balancing out the different type of formulations is where you want to go, because those that don't understand are going to unfortunately still give you misinformation. And speaking of misinformation, when do we stop estrogen? That's the number one question. Well, how long do I need to take this? It's like, hey, you don't need to take it at all. I mean, if you want to take it, I understand these are the benefits that it can give you, but there is no cutoff for hormone therapy, right? Women can continue hormone therapy as long as the benefits outweigh the risk. And that is going to be a personalized decision for each patient. But at the end of the day, we know that if you stop estrogen, there's at least 50 to 87% of symptoms are going to recur in women after stopping it. And so understanding that you don't have to suffer, but don't, again, confuse taking estrogen with all the other lifestyle things that you need to consider. You need to look at your movement, your sleep, again, keeping your weight down, and your alcohol use. These are all things that also affect how you're going to feel and your perimenopause journey. But know that it's a personal kind of formula for each person, but it is still going to be the best treatment for some women, especially as it relates to what we call the genital urinary syndrome of menopause. That is a real thing. And we know that estrogen is completely safe in these conditions. So women that are having vaginal dryness, pain with intercourse, increased urinary tract infections, frequency, urgency, understand that the vagina and the urethra say that they share real estate. And what happens in the vagina happens in the urethra. So we do want to keep the pH balance. We do want to keep the bacteria that like to live in the vagina, and it's normal. But when estrogen levels decline, that pH balance changes. We go from an acidic to an alkaline pH balance that allows the overgrowth of certain bacteria. And this is where we get into maybe more incidences of bacterial vaginosis, urinary tract infections. Understand that estrogen vaginally is completely safe. There are no issues there. There are even giving vaginal estrogen to breast cancer patients now who are on breast cancer therapies. So understand that it is safe. And if you're not going to take estrogen or put it anywhere else, know that it is okay to put it in the vagina. And I'm going to leave it there. So yeah, this is a quickie one, guys. I wanted to just give you some insight on this FDA removal of the black box. What does that mean? What does that mean about estrogen? Estrogen is safe. It's been safe. The FDA and everyone else is now starting to appreciate it. Estrogen is not the panacea. It is not going to prevent dementia. So even though we took these black box warnings off, we also don't want to go in the direction of just putting out information that is not correct, that is not factual, and is not based in science. So yes, estrogen will ultimately affect our brain health, but it's more affecting our brain health as a result of the fact that it's decreasing hot flashes and really helping with those vasomotor symptoms. Because even when you give those drugs that I mentioned, those neurokinin B receptor medications that stop the vasomotor symptoms by acting centrally, we know that that actually can improve a woman's cognition and her productivity the next day. Because why? Because she slept. So at the end of the day, sleep is king. And we know that when things disrupt our sleep, disrupt us with these vasomotor symptoms that cause these hot flashes, then those are going to impact our cognition. And so anything that helps to diminish that is going to help us. All right. So short and sweet this time, guys. As usual, like I said, friends don't let friends go through menopause alone without support. Reach out to a friend, have the conversation, share the podcast, and, do all the things. Please download, make your comments. Thank you for those that are commenting. It really does warm my heart. I like to know that you're listening out there and I'm not just looking at a screen. I know that you're out there. I hear you in the clinic. I hear you when I'm out, and I'm so always happy to hear that it's being helpful. We have lost 2 decades in this FDA black box. And now I think this is the time where we're really starting to be able to reclaim our power. And I am here to encourage that empowerment on the journey. Get your knowledge, understand the facts, love TikTok, but just remember, everything you hear isn't true. Everything you see on the internet, everything you read is not true. I would love to continue to be your reliable source for all things menopause and all of the science and keeping you up to date. As usual, stay brilliant, stay beautiful, but most of all, stay juicy, and I'll see you on the next one.